The quality of my voice good for you?
Yeah, it's good. So
Okay.
All right, so here we go. Well, welcome everybody. We've got little technical issues here, but we're up and running now. So I just wanted to introduce everyone that's involved here. We have Dr. Peter LeWitt, and you're in Detroit, I believe. Is that not correct?
That's right, Motor City.
And he's a neurologist, and I've got all your letters here, but I'll let you kind of explain who all that is, and when you introduce yourself. And then we have some guests, Joe and Sarah Possenti. Possenti. And they're from Philadelphia, so they're going to be sharing with us as well. So LifeScope, I was really excited to introduce you guys. Anyone that's dealing with Parkinson's or dealing with understands what the term off moments are or off periods are. You're kind of from my own family, we have Parkinson's in the family, so you're fighting this balance between off periods and dyskinesia, and so I'm going to turn this over and I'll shut up and let you guys all go here. So I guess we'll start with Dr. LeWitt. I'm going to let you kind of introduce yourself and tell us all
right, I'll explain myself. So I'm a neurologist based at Wayne State University School of Medicine, also at Henry Ford Hospital. I've subspecialized in movement disorders, of which most of my practice over many years has been Parkinson's disease. I've been involved in the development of new therapies for Parkinson's, as well as having a training program for new doctors. So I've very much been in the thick of things with patients. Someone asked me to calculate how many patients I've cared for or got to know over the years. It's a big number, but every patient's new to me in terms of the way I approach them. And I hope we can talk today about one of the most common problems that plagues people who have Parkinson's disease, who find good results from levodopa, and yet after a few years have that phenomenon called off episodes. And that will be the focus of this discussion. So let's pull up the next slide.
Brandon, you gonna pull our slides up for us?
Yep.
And so the topic is going to be off episodes. We'll define them, and I hope we'll have a chance to go over what has been a challenging issue for more than 3 decades in the management of people who take levodopa and yet don't have a full, systematic, continuous level of control. Next slide. So these are the topics then, ending in a therapy, the drug apocrine or apomorphine, that can be used to treat off episodes. But first, let's start with what causes these motor symptoms. Why doesn't levodopa work consistently? How are motor symptoms treated? And what are the different categories of these off episodes? So next slide, please. And next. So Parkinson's disease is not a rare condition. In fact, it's one of the most common neurological conditions. It's chronic, sometimes beginning in one's 40s or 50s. An estimated 10 million people worldwide are affected, and in the United States, nearly 1 million people are affected, with an estimated 60,000 new diagnoses of this disorder each year. And the incidence is increasing for several reasons, plus people are living longer. So up to 20% of Parkinson's diagnoses are not necessarily people of the average age of 58, but are under the age of 50. So it's not just a disorder of increased age. The experience of living with Parkinson's is quite unique to each person. There's some general properties of symptomatology. Some people have tremors, some don't. But in general, everyone cuts their own path, as they say. Next slide. So you're not alone, but you're unique. And Parkinson's, in essence, occurs when the signaling or communication in the brain between nerve cells is disrupted, especially in that territory where movement or motor abilities are controlled. So this movement is controlled by a particular signaling chemical called dopamine. It helps nerve cells in that specific movement disorder region, movement control region, to be disrupted. And the number of those cells is very much diminished by the time you even have the earliest symptoms of Parkinson's disease. Hence, the communication between this region of the brain and the movements that occur in limbs and in your speech and all body movements are very much affected by dopamine deficiency. Next slide. That's a simplistic view of things, but that's why taking a medication to replace the missing dopamine makes a lot of sense. So early on in Parkinson's, the symptoms can be quite mild and intermittent and subtle, sometimes more observed by someone living with Parkinson's than outsiders. There can be involuntary trembling or shaking of limbs, or sometimes just even a few fingers. There can be muscle stiffness or difficulties with ease and range of motion. But the hallmark of this disorder is slowness of movement in both starting to move and continuing to move. And sometimes it can be so severe that there's hesitation, the feet not responding to the will to move, as James Parkinson once described it. There can be, as time goes by, other problems such as impaired balance, freezing or instability in moving forward, and other functions that are motor system in control of movement include difficulties with swallowing or speech. Not everybody has all these features. They're not necessarily there from the start, but this is the spectrum of the kinds of things that can occur with Parkinson's, and most of these respond very well to that medication, Levodopa. Long-term treatment, however, with this medication can lead to motor complications, that is, inconsistency of effect, involuntary movements, possibly others. Next slide. So living well with Parkinson's is a challenge. It sometimes requires us to master the situations that lead to fluctuations, to live with a regular schedule of medication intake, sometimes to combine several different medicines to achieve the goal of as much continuity as you can. And keep in mind that you have to have a holistic approach to Parkinson's. Not everything that ails you is necessarily Parkinson's. Sometimes being very tired in the afternoon makes you feel weak, makes you think the Parkinson's symptoms worse, but you're just plain tired. So it's important to take stock of your overall health, exercise, improving endurance by various forms of exercise, sleeping well. Many patients with Parkinson's find it clearly sabotages their day with Parkinson's symptoms if they haven't been well rested. And a healthy diet is good for all of us, especially those with Parkinson's. Next slide. Staying active with Parkinson's is supported by research that shows exercise, any kind of exercise, but endurance-related, range of motion, working on balance, working on a vigorous stride, all can have a positive outcome with respect to reducing the risk for falls, improving your mental state, and taking away anxiety or feelings of excessive fatigue. It can also improve appetite and quality of sleep. And so that's good advice for all of us for your general health, but especially Parkinson's disease. And there actually is some very solid research suggesting that even relatively light exercise is especially effective. Next slide. Eating well is not well supported as to what exactly to eat, but a balanced diet consisting of whole foods, fruits, vegetables, and lean protein are recommended for everyone. There's internet information suggesting that you should stay away from protein. It just isn't true. Some people are sensitive to protein and temporarily interfering with levodopa, but that's a rare person, and that's worth checking with your doctor. In general, nothing needs to be restricted in your diet or supplemented with vitamins or other supportive intake. It's also important to stay well hydrated, but that's true for all of us. Swallowing problems can occur in Parkinson's, and if you do have that, it's worth getting it evaluated from the point of view of a speech and swallow expert and determine if, in fact, you should be careful with liquid intake or solid food. So diet and medication is important to think about for the following reasons. The high protein intake, as I mentioned earlier, sometimes lessens the effectiveness of a particular dose of levodopa. It isn't something you should assume is affecting you unless it's been evaluated by trying out a high dose meal of protein during the day and a low dose and see if you feel any different. In general, keep in mind that most people are not sensitive to this. However, many of us have relatively high protein diets, and it could be a factor for some people on levodopa. Next slide. And sleeping well is important because of a few things. First of all, with Parkinson's symptoms reemerging during the nighttime, it's possible that you could have tremors or muscle cramping that are particular features of Parkinson's as levodopa wears off during the night that could awaken you. Furthermore, some people with Parkinson's have something called acting out of dreams, or REM sleep behavior disorder. REM stands for rapid eye movement, a light stage of sleep where dreaming occurs. And during that time, one can have the problems of movements, even running in sleep, falling out of bed. But furthermore, if you're in a light stage of sleep for many hours of the night with this condition, you're not really getting restful sleep, even though you're not wide awake. So it's important, if you have sleep disruption, to talk to your physician about that. There are evaluations for that latter condition, REM behavioral disorder, acting out of dreams, and medication treatment for that, and also recognition that it is occurring so that you don't have to be tired during the day on a regular basis, even though you think you slept 6 or 7 hours. Restful sleep is very much helped by creating a bedtime routine, avoiding alcohol or caffeine later in the day in general, and making exercise an earlier day phenomena. These are just some hints for how to improve sleep if you're not sleeping well. Next slide. And treating Parkinson's is generally accomplished best with a medication that's been around for more than 50 years, levodopa. It's the gold standard of treatment. It's the most logical therapy because it helps to replace the missing dopamine that is characteristic of this disorder. There are also drugs called dopamine agonists that are taken orally that mimic the effects of dopamine and sometimes are used together with levodopa. They're not better as a solo therapy, but the combination can be very much improved. And there are other drugs that are used to augment the effects of levodopa, drugs that are called MAOB and COMT inhibitors. These drugs, in essence, make a single dose of levodopa last a little bit longer if someone is having motor fluctuations, that is, limited duration of action of levodopa. Next slide, please. So I started out this talk mentioning that there are such a thing as off episodes, and the opposite is on. On is when Parkinson medication, especially levodopa, is working well, where the symptoms are completely or mostly controlled. The goal of therapy, of course, being all day, all night, good control. But it sometimes is not that easy to accomplish from levodopa alone. And even the drugs that extend its effect are sometimes not 100% effective. So the off episodes usually mean a gap in the uptake or the consistency of uptake of levodopa, which by itself at most in many people has no more than 2 to 3 hours of duration each time you take it. There is an extended release form of levodopa, and it is possible to take the medication at intervals of 2 or 3 hours to overlap doses. But even in those circumstances, there still can be off time. The medication may not be absorbed efficiently, even though you took it on time. It may be too that there are mechanisms in the brain that somehow block the effectiveness of a particular dose, predictably or unpredictably. So an off episode is when there are reemergences of Parkinson's symptoms, such as tremors, slowness of movement, maybe hesitancy in moving, speech that goes soft, handwriting that trails off. All of these symptoms may be due to the fact that the drug just hasn't gotten absorbed, or there may be other factors that are very hard to tease out in any one person. Next slide. So off episodes, as mentioned, could be because your GI tract isn't absorbing well. For example, if you take levodopa with a meal, your stomach is involved in digesting that meal, and during that time, your medication won't be absorbed. Your medicine has to go beyond the stomach, get absorbed to relieve Parkinson's symptoms. And while your stomach is engaged in 30 or 45 minutes of digestion, that just isn't going to happen. So certainly the ideal way to take levodopa is a half hour before or an hour after a meal. But that's just a simple fix. After 5 years or more, most people who are on levodopa are doing well. Not everyone, but even if the drug is doing perfectly well when you're completely on, there may be hours per day where you're not in that particularly on state. And these off episodes, unfortunately, can be unpredictable and can come on relatively abruptly because levodopa is a relatively short-acting drug. So this could be termed dose failure or delayed or suboptimal on states. In other words, the most rapid onset of medication effect from oral levodopa tablets is about 15 or 20 minutes. That's the ideal. But in some circumstances, sometimes a day, maybe because of residual food in your stomach, it might be 30 or 45 minutes or even longer. And certain people experience doses that just don't get absorbed, even though they took it with water and on an empty stomach. The stomach is not a perfect way to deliver a medication like levodopa. So these can be both unpredictable episodes of off, or it might happen every day at 3 o'clock in the afternoon for reasons that you can't figure out. In any case, those are challenging parts of living with the disorder, even though the drug continues to work when it does work. And of course, overnight, if you haven't taken medication since 7 o'clock in the evening the night before, levodopa is short enough acting that when you wake up in the morning, there's no medication in your system. And that's called morning off. Waiting for the next dose to kick in is sometimes a long wait. Next slide. So in surveys that have been carried out, and this is several years often into treating Parkinson's with levodopa, approximately half of people experience off episodes. And over time, the response to oral levodopa may become increasingly unreliable or unpredictable. In other words, it isn't just 3 hours later, time to take the next dose, and occasionally that dose doesn't work. No, it can be even more chaotic than that. And that makes a real impact on planning in life, as well as just distress of, why can't I figure out how to take this medication better? Off episodes can be more severe. Sometimes you just cannot move at all, even though years ago when it wore off, it was just a little bit of tremor. So this is a challenge, sometimes beginning as early as 2 years after the onset of your levodopa treatment. And this isn't really progression of Parkinson's disease. This is irregularity of medication giving you that symptomatic relief that years earlier, you never had these fluctuations. It's frustrating. Next slide. So off episodes are not really well understood, as I've implied. It may be that it's your GI tract just not absorbing the drug. If we could measure your blood levels of levodopa at different times of the day, and this has been done in research studies, we might discover that the amount that's been absorbed isn't sufficient to give symptom relief. And that's an easy answer. Unfortunately, how do you deal with that? There aren't better products to give necessarily to get a more constant blood level. But that is one of the issues that for many people is the full explanation. Next slide. Well, here we see a cartoon of the GI tract not quite doing what it should. Next slide. And there seems to be a relative blockage. In fact, that picture just passed by there shows someone who had a scoping, the kind of thing you do when you're evaluating for swallowing difficulties or stomach acid reflux, whatever. And in that picture, in the interior of your stomach, you can see a carbidopa, levodopa, or Sinemet pill that was taken by that person an hour and a half earlier, not digested, not absorbed, just sitting there having a siesta. And we call that sometimes siesta stomach syndrome. In other words, you took the medicine on time, and yet a particular dose might not be absorbed, or 2 hours later, it might be suddenly absorbed, but you're not expecting it. So that's the challenge of living with Parkinson's on levodopa. Next slide. So about 2/3 of people, when they do have motor fluctuations, have 2 or more hours per day. That's more than 59 hours per month if you do the math. And more than 90% of people, after a few years, 2 or more years, in this survey carried out by the Michael J. Fox Foundation, experience motor fluctuations for various reasons. And of course, this is assuming perfect compliance. Anytime you forgot to take a dose of medicine, there's another reason to have an off episodes. And about 50% of the times, the off episodes cause a change in your behavior. If you're living the life of motor fluctuations, you may not be planning events, social or work, in the manner that you would if you didn't have this potential disability. Next slide. So that's the overview of Parkinson's and off episodes that I have to offer. I'd be glad to go on at length about this, but we have other folks to talk about this. Now I'm going to shift gears into at least one way to deal with off episodes, an on-demand treatment that has been marketed in the US for more than 15 years. It's a medication that's been available around the world. It's an old drug that's been harnessed to be given subcutaneously, an injection called apokine. The generic name of the drug is apomorphine. I should point out, even though it has morphine in the name, it is not a narcotic. It's not habit forming. It's a different drug and just has a chemical structure that is similar to morphine, the narcotic drug. Apomorphine or apokine is used as needed to treat an off episode in people who've had motor fluctuations or advanced Parkinson's disease. And it's not used to prevent off episodes. It's used to treat them when they're occurring at your choice as a patient. And it doesn't take the place of other medications for Parkinson's disease, such as levodopa. It's just a way to fill in for the failure of that oral medication regimen to do the job that other times of your day it does. It's a portable and convenient therapy. You see the kit up in the upper left corner, a penject system that you can carry around in your pocket or park in different parts of your house, ready to go. The drug is in liquid form in cartridges, and people who use it are instructed and given the chance to learn with supervision how to use it so they can make good choices as to when it should be used and what to expect and how it can be used safely. Next slide. So here's some important safety information. I'll just point out some highlights of it. For one thing, don't take apokine if you're taking certain drugs that are known to have interactions with it. We can describe that to you in detail when it's being suggested for your use. These drugs that interact with it are quite few, but it's important that your pharmacist and you know that there might be some drug interactions. And don't use apokine if you happen to be allergic to metabisulfite, which is its preservative. Next slide. Keep in mind that the medical conditions such as fainting spells, low blood pressure, for example, or dizziness might be conditions that you could have some interaction with apokine. So being very clear about your medical past and possible side effects that might be exacerbated by apokine are well worth a discussion with your prescriber. Apokine must be injected under the skin and not into a vein, but you're trained in how to use this drug when the drug is prescribed for the first time. Next slide. So how does it work? Well, I mentioned a chemical called dopamine in the brain. Apomorphine or apokine is a drug that mimics the action of this natural signaling compound. It doesn't get absorbed through the GI tract by injecting it under the skin. It's absorbed in your bloodstream independently of what's going on in your GI tract. And it's an effect that is fairly rapid in onset, hence quite reliable and going to work, lasting for 60 to 90 minutes until the next oral dose of levodopa can begin to work. So this is the Johnny on the spot, rapid onset of effect, awaiting the effect of levodopa sort of to take over for the rest of that dose cycle. Apokine can be added to almost any Parkinson's disease treatment regimen. Medications that are used for Parkinson's do not adversely interact with this drug. Next slide. And it's proven by clinical studies that were carried out in the US and which is well known worldwide. Apokine rapidly, as soon as 10 minutes in the typical patient, can have a significant improvement in their ability to move. So the off episode can melt away faster in general than what oral levodopa can accomplish. And in the study that was carried out, and I was one of the investigators in that, 95% of off episodes were successfully reversed by an injection of apokine or apomorphine. So this is a drug that is quite reliable, rapid, and the effectiveness of it was quite robust. That is, 90% of patients in these studies that were carried out under observation achieved their best oral levodopa-like effect by 20 minutes afterwards. So the effect starts to work at least as soon as 10 minutes, and by 20 minutes, it's like the full effect of levodopa, which is something that levodopa doesn't always accomplish. It can work at any time of the day. No need to plan around meal times, for example. It can work at night when you haven't taken levodopa or first thing in the morning. Next slide. And a clinical trial also established that 97% of morning off episodes were reversed with apokine used in a real world fashion. And in another clinical trial, 96% of patients saw improvements in their time to on in the morning with apokine compared to oral levodopa only. So the rapidity and the reliability of effect, as well as its robustness, are established in clinical research that's been carried out as the drug came onto the market. Next slide. So other safety information I can mention, and these are usually brought out in discussions with your prescribing physician if they apply to you. For example, the apokine can lower your blood pressure, as other Parkinson drugs do. So if you have low blood pressure to begin with, or as you're first started out on this drug, your blood pressure is monitored. And it is always useful to keep in mind that as rapidly as this drug kicks in, its blood pressure lowering effect, if it's significant for you, might be evident within 10 to 20 minutes. So that's just one concern. Other patients have had nausea or a sense of dizziness with the use of the drug, and this may be something relevant to adjusting the dose so that you don't have side effects as the drug continues to be used. Next slide. So to summarize a few things mentioned, it's used along with all of your other Parkinson medications. It's a small injection under the skin called subcutaneous, the same way insulin is given. It's injected using a very thin needle, similar to the patient who's taking insulin on a daily basis. And it bypasses the GI tract in this manner. It works reliably in as little as 10 minutes. And once you've been trained and established what your ideal dose is, your care partner or you can use the apokine pen on a regular basis. It can be used as needed up to 5 times per day. Next slide. So here's a few examples of real use of it. Dave is a real apokine patient who has been experiencing office episodes. Let's see what he's like before in his Parkinsonian state and after using apokine.
This side is definitely harder. You can see my right side starting to tighten up.
So there you see the relative slowness of movement of Dave as he sits doing exams as asked. So we're going to see him in contrast after the injection of apokine. He's stamping his feet. He's not doing this involuntarily. He's showing Parkinsonian symptoms of slowness. The injection is given. And the time point for what we're going to see in a moment is about, I think, about 10 minutes later. But first, there's the injection. He's injecting in his abdomen. There are other places like your arm or leg, which could also be the subcutaneous sites. All right, so there's on the left, Dave, in that slow hand tapping. And you know what, this, the way that this being projected is not going to show in real time. It's not speeding up. So let's go past this. So Dave basically becomes normal in this sequence. So other safety information is shown here. I know you can't read it all quickly. And I'll just highlight a few points. Some people may notice soreness, redness, bruising, skin nodules where the injections are repeatedly given. It's recommended that you rotate these sites, but sometimes just because any injection under the skin can cause some of these phenomena to occur. And if you experience any adverse effects such as shortness of breath, faintness, change in your heartbeat, pains in your chest, anything that's a side effect, of course, stop using Apokine and let your physician know. Other recommendations will come to you in written form if this is prescribed for you. Next slide. And there is a program that the sponsor, Supernus, offers with respect to the prescription of Apokine. This is called the Circle of Care program. It's available to you for services, for information. It may be part of the clinical educator who comes to your home to get you started, who will be there to support you in any questions that come up. This is beyond your prescribing physician services in terms of getting you started on Apokine, and other details are described here. Next slide. So, are you the person who could benefit from this? Are you having motor fluctuations and off time? If so, have a discussion with your physician about this. This is typically this kind of symptomatology that's described here. Difficulty getting started in the morning. Are there times when your oral levodopa takes too long to work? And I'm talking about 30 to 60 minutes or certain doses not working at all. Are there times when your oral levodopa medication suddenly stops and seems to be relatively unpredictable, even though you're taking it right on time? Do you find that your activities that you'd like to plan for just can't be planned because of too many embarrassing or frustrating situations? Are there times when you're very self-conscious about the reemergence of tremors coming back, or you can't speak clearly because you're under-medicated? If so, this is the kind of therapy that you have control over your symptoms. This is an on-demand treatment when you feel you need it, up to 5 times per day. Next slide. And these are just some points that we made earlier. It can be used with all the other Parkinson medications and a variety of motor symptoms: walking, speech, getting out of a chair, handwriting. All of these things can respond to the same kind of effects that you used to get regularly from levodopa. Next slide. And there's more information available on this drug, a great deal that's known by physicians and other patients. So there's a QR code to learn more about, and possibly to register if you wish for updates about Apokine. And there's a mentor program where you can talk to a real person with Parkinson's disease taking Apokine. There's the phone number. Next slide. So, any questions from out there?
Jim, is there anything that you would like to ask Dr. LeWitt? You're muted.
You're on mute, Jim.
Yes, I'm sorry. I had it on mute. So anyway, yeah, the question I was going to say is that you made a comment about the cost. It could be, there could be some help or assistance with that. I don't know what the cost of this drug is. I don't know. Is there anything does it work with like Medicare? And I mean, could you kind of answer that for us? Whoever is the right one for that.
You want me to take that, Doc?
Well, I could comment. First of all, this is an FDA-approved medication. Medicare, to my understanding, provides coverage if prescribed. It's a medication that is generally sent to you from a central pharmacy. So the arrangements for the supplies you need as well as the drug are all bundled together, as is the services of getting educated in how to use it in your home if you wish. The costs of the drug, though, I think vary greatly among people who have different prescription plans, who have perhaps different copays, different plans that have you meeting certain costs up to a certain level. So I'm not really an expert on that. I know that most patients have a way to get onto the drug if they need it and if they wish to continue once they've had a trial period with it.
Yeah, and we
It's
have
not prohibitive. We're getting people that are getting hooked up to it pretty well.
we have
What you're saying.
the circle of care, which was one of the last couple slides. So there's a case manager and a clinical educator as well. The clinical educator will go help the patient to make sure they're the right, that they respond well to Apokyn. And then also the case managers also help with getting approvals and working with the doctor's office staff on shipments and all that as well as finding funding and applying copay cards and all that fun stuff.
Excellent. Hey, Brandon, you want to go ahead and undo the screen share so that way we can see all your faces and stuff? That would be cool. So there you go. Thank you. So what do people ever have? I mean, how quickly do people know if this is going to be a good drug for them? If it's good, and I guess one thing we need to be doing is I'm looking forward to hearing Joe and Sarah talk as well on this whole thing. But so what kind of guide me on what if someone's looking into this, that maybe they're having some off period, is this something that they can kind of go in and out of? I mean, drugs sometimes are so scary on how you're getting into them. I know my wife right now was talking about, they were talking about something with her, and if you get into it, then it takes forever to get off of it type thing. So how does this work in that? Is it something you can try out? If it works for you, then great. If it doesn't, it's not going to be a big impact, or how does that work?
Yeah, no, that's exactly the situation. Like all medications, first of all, it has to have a meaningful effect on you. Some people are needle phobic. The idea of injecting a medication may be new to them. It's also the experience of someone with diabetes who has to start on insulin. In some instances, the nature of off episodes may not be as troubling as it is for the next person. So the physician, really is sort of offering an option, but the patient, the customer, has a chance to decide, is it really meaningful in their life? Are these off episodes having a real impact that need to be fixed? I mentioned other options for trying to improve off episodes, such as adjunctive medications or drugs, changed schedule of intake so that there's fewer gaps. But still, everyone who would choose this therapy is trying it out for the first time to see if it agrees with them. And in many instances, just a few injections per week is enough to justify its use. Some people carry Apokyn around just as sort of like a security blanket, so that if they ever have an episode in a situation where they may not feel safe, for example, driving their car or out for dinner with friends and not wanting to have to be carried out of a restaurant, as some people have had that experience, it can make a very important impact on your quality of life, even though it's the same quality of medication effect that people count on getting from Levodopa at other times of their week. So it's not a necessary drug. It's just a real convenience to have something that's reliable and highly effective.
So it's almost like an insurance policy for some people too, like for, so they can have the quality of life of being able to go and do things and not be afraid that they're going to get frozen, quote unquote, someplace. Is that kind of what you're saying here? Or?
That's right. Yeah. And the freezing up is just the absence of medication that even if you took it on time, that pill could be parked in your stomach, not absorbed for nothing that you did to make that happen. Or let's say you've had a big meal and then, my goodness, I forgot to take medication. And you know that until that meal is digested 30 or 45 minutes later, no matter how many pills you take, they're not going to absorb until there's space in your stomach and the ability to absorb the levodopa.
So another question is, if you're taking your meds on time or whatever, and then you have that off period that hits, this doesn't hurt that you're like overlapping them or what have you. It's not going to make a difference to you if you're not going to be like over drugged. Is that, I'm just trying to ask,
Well, I mean, here's the situation. Many people, not everyone who take levodopa have involuntary movements, dyskinesias. These are typically over medication symptoms. And so if you're that person, and it's about 1/3 to 1/2 of people with Parkinson's after 5 years have involuntary movements of some sort, very mild in some instances, quite prominent in others. Apomorphine could also cause those. And so as you determine what's your optimal dose of apomorphine, one of the guides to what dose to use might be keeping below the dose that would cause a lot of involuntary movements as a side effect. Or let's say there's some levodopa effect still there. You're sort of going off, but you still have some effect there. You can dial back on the dose of apokine as is given. So if your typical dose, just to pick a number, is 4, you can go to 3, and therefore have less chance of causing the side effect. Some people find that they yawn as a side effect. That was on the side effect list. Yawning is a side effect, not that they're tired, but it just causes yawning. Let's say they're in a social situation where yawning ain't that polite. So a lower dose can be given, even though it might not be the full effect, but nonetheless, the patient has a chance to choose what side effects as well as what benefits they might get from a particular choice of dose.
That's great. That's what I was trying to find out. So do you have something you want to make sure that people are aware of beyond what the slides did?
I'll just share this. It's a very much underutilized treatment. It's not new. I think it went on to be available in, I think, 2006 or so. So many years it's been out there as a prescribable drug. Considering the number of people out there in the United States who have off episodes, my information suggests that it's very much underutilized. A lot of physicians aren't experienced in its use. They haven't heard from patients that off episodes are a real problem. So be an activist, if that's part of your experience with Parkinson's. Say that you've heard about ways to treat off episodes and you'd rather not have to live through them. And there are many ways to manage off episodes, not just apokine, but this is an established treatment. It's not experimental. It's generally very well tolerated, and there's a lot of expertise over the years of how to use it well to improve your quality of life.
Excellent. I appreciate that. So Brady, do you want to introduce your guest or?
Yeah, so we got Joe and Sarah here. Joe has Parkinson's, and I'll let them kind of tell their story. So Joe, Sarah.
Thanks so much. Sure. My name is Sarah, and I'm married to Joe, and Joe's had Parkinson's for 14 years. He was diagnosed when he was 42. But before we start our story, I just want to say thanks to Supernus for sponsoring us to be here. And we really appreciate being able to be a part of something like this. And then also emphasize how important it is to read the prescribing information and all the side effect information and that kind of thing before you start Apokine. So.
Hi, I'm Joe. You can tell I'm the one with Parkinson's, but it's always nice to follow Dr. LeWitt. I haven't seen him in a long time. He's one of my favorite doctors I've ever met doing these speaking engagements we do. He's just so knowledgeable. What we like to do is just tell you our story, how we met, how we're doing living with Parkinson's, and hopefully you get something out of it, and how this medication has really helped us, help us be hopeful moving into the future. Just give you a little background. I grew up in a really great family, Irish, Italian parents. I have 4 younger brothers. I played college football at Temple, and I tried out for the Eagles in 1988. And my brothers all played college ball with us. We played together. And then after that, I coached high school football 5 years as an assistant and then a head coach for 10 years. So football was a big part of my life. And I look back now, the work that I put in coaching football and playing football and all the off-season training, has really helped me with fighting this Parkinson's disease, because it's very similar to football, that it's ever changing. You don't know what to expect. It's the biggest opponent I've ever had to face, and it's tough. You got to really battle, and you got to prepare. You got to prioritize, and it can be difficult, but it also can be a great challenge that I've accepted and I continue to fight for. But as I got done to the end of my coaching career, I started to experience a lot of symptoms, a lot of stiffness, a lot of pain in my shoulders, pretty much down to my feet. And I just thought it was old football injury. So I pretty much blew it off, didn't get checked out, figured I have to live with this. And as an old time football player, it's like a badge of honor to go around and tell everybody what hurts. But then finally, after I got done playing, I was working for my dad's accounting firm, and a client of mine came in. I went to high school with her. I hadn't seen her in about 10 years. And she thought I had suffered a stroke. And I was about 42, 43 at the time. And it sort of blew me away. And that's when I decided to go get checked out by a doctor. I went to an orthopedic guy first. And he said that, these are just look like old football injuries, but I want you to go see a neurologist. I was kind of puzzled, but I went and saw a neurologist, and within 20 minutes or so, he said, I guess seeing me walking up and down the hall, how I was moving, how so stiff I was, he diagnosed me with Parkinson's. And my mom was with me at the time, and we cried all the way home. It was difficult. I was going through a divorce at the time. I had 4 young kids at home, and my father had just passed away a few months prior to that, and we were partners in this business. So this was another black cloud over my head. And to be honest, initially I didn't take the challenge on. I pretty much went and sat on the bench, and my kids suffered because of it. And I had 3 daughters and a son, and at that time they were 12 and under. The youngest being 7 or 6 or 7 at the time, and it really affected them, and it affected my work. My employees suffered because of it, and I really regret that looking back now, putting people, my kids and my employees in that position. But thank God my mom, who was my savior at the time, she finally said, you got to get off your butt here, Joe, and go out and meet somebody. Your kids are counting on you. So I figured, pushing 45, 50 years old, I got Parkinson's, I got 4 young kids at home, I'd be a hell of a catch on online dating. So I figured, let me try the online dating. And if we had a couple hours, I'll tell you about the first 50 or 60 dates when I was so nervous I'd over medicate, and I was shaking. They looked at me like I was nuts, because you don't put Parkinson's in your profile. But then when I finally met Sarah online, and when I saw her come into the restaurant with a seeing-eye dog, I'm like, this is perfect for me. And so that's when my things started to change for me. I found somebody who didn't see the Parkinson's, actually saw me, and I finally decided, let's get off the bench here. And Sarah took over from there.
My vision is just fine, everyone. Joe and I did meet online, and I will never forget our first phone call. It was about 2:00 in the afternoon on a Sunday in April. And I could not understand a thing that Joe was saying. It sounded like he was slurring his words. I kept having to ask him to repeat himself. And then at one point, I leaned over to my daughter who was sitting next to me on the couch, and I said, I think this guy is already drunk. So this red flag had gone up for me that day, but Joe sent me some text messages and invited me out to lunch. And so I agreed to meet him, and Joe was late for our first date.
If you ever have to parallel park in the city of Philadelphia, you'll understand why I was late.
Fair. But by the time Joe got there, I was completely done with this guy. I was like, that's it. There's something wrong here, and I'm having the lobster and he's paying.
Yeah, I'm still paying.
No. So we had a really nice time. Joe made me laugh. He still does. And we had a great lunch, and Joe walked me back to his office, my office, which was about 7 blocks from where we had lunch. And Joe asked me if I would see him again. And I said yes.
That's when I ran the Rocky stairs. That was the first time, to be perfectly honest with you, on the the online dating I was on that I had a second date. And so that's when I thought our vision had to be bad, or I must have been pretty funny.
So after Joe left, I called my oldest daughter who was in college just to let her know that I was okay, because it's a blind date, you know, when you go on a dating site. And I told her about Joe, and I said, you know, oh, he's tall, dark, and handsome. He's just my type. And she was like, that's great, Mom. And I said, yeah, I said, I had the lobster salad and he paid. And she said, oh, Mom, that's great. And I said, yeah, and I'm going to see him again. And she said, Mom, that's great. And I said, yeah, I said, I'm excited. And there's something about him though. And she said, what? And I said, I think he has Parkinson's disease or maybe MS. And she just said, oh my gosh, Mom, you have to find something wrong with every guy you date. She said, maybe he was just nervous. But I didn't think that Joe was just nervous. And the reason why is because my uncle had Parkinson's disease for about 30 years. And what I knew about the disease were a lot of the involuntary movements that I was seeing with Joe at lunch, but I was especially seeing them in his hands, which is why I also thought it could have been MS. But my uncle has had gone downhill, terrible tremor, taken, you know, up to 29 pills a day. And about halfway through his battle with the disease, he was so dyskinetic that he was falling all the time. I saw him at my cousin's wedding, and he was trying to film well wishes for the bride, and it was just, you know, he couldn't hold the camera straight. And I saw him again though about 3 years later at my brother's wedding out in California, and he was walking around and he was dancing with my aunt, and he looked great. So I said to my dad, I was like, Dad, what the heck with Uncle Dick? He looks great. And Dad said, oh yeah, he had that brain surgery and he's even driving his RV again. So I tell you guys the story because that was the story that I told Joe on our third date when he asked me, or when he told me that he in fact had Parkinson's disease.
I figured I better tell her because those lobster lunches were getting real expensive. Figuring she'd run out the door, but she didn't do that. And I tell everybody that it's like she got on the high dive with the pool and dove in, and there was no water in the pool. That's the leap of faith he took in me. And then that's when I realized, you know, I want to be with her, and I think you know, things could be pretty good back the way they used to be. But we started dating, having a great time, but I was still going downhill. My symptoms, especially the non-motor symptoms. People realize Parkinson's, they think it's all motor symptoms, where it's stiffness and the medicine calls them dyskinesia and the involuntary movements. But the non-motor symptoms, the apathy, the not being able to multitask, the not being able to remember things, your handwriting getting bad. I mean, they were things that really bothered me. The apathy really bothered me. I mean, I sometimes, when medicine wasn't kicking in, I'd sit on a chair and feel like there was an elephant sitting on top of me. It was horrible. And I just couldn't move. And so we dated, we're having a good time, but I was having more difficult times buttoning my shirt. I mean, I go into a store and you go up to the counter and you're going to pay for your stuff. I couldn't get my hand in my pocket sometimes. And then the line starts building up behind you, and then the anxiety starts getting, and your symptoms start to flare. And it became very frustrating. So I go to see my doctor twice a year, and I used to go myself and always tell him everything's fine and dandy. And then I leave, and I was like, I didn't say anything to him. So finally, about 8 months into our relationship, we're getting pretty close. Sarah asked me if I could she asked if she could go to my doctor's appointment with me. And hesitantly, my doctor's pretty well known in the area. He used to be a patent attorney before he was a neurologist. So he's brilliant. So I didn't want to even question him, because he could tell me all the right things. But she came and things changed.
And I started asking questions. So when Joe told me that I could come to the doctor's appointment, that was kind of the day that I deemed myself Google doctor. And I went online and I started doing research and signing up for reputable websites and newsletters. And I ordered the Every Victory Counts book from the Finney Foundation. I started also journaling and writing things down that Joe was doing, that I think that he was treating kind of like his new normal, that I thought maybe that we could ask the doctor about. So the day that we go to the doctor's office, Joe's driving and I'm reading like, you need to ask the doctor about this, Joe. And he's like, okay. And I'm like, and ask him about this. And he's like, I will.
I'm
Yeah.
just trying to stay between the lines. We're on the highway. It's tough enough with Parkinson's driving, and I got her chirping in my ear.
Yes.
And that's where the multitasking comes in. They can't do it. So I wasn't really listening too well.
So we go into the doctor's office and we sit down and all the niceties and, and Joe introduces me. This is my girlfriend, Sarah. And the doctor says, so how are you doing, Joe?
What I told him for the prior 7 or 8 years that I go to him twice a year, I'm doing great, Doc. How are you doing? And that's when I could see the smoke and come out of her ears and nose.
Yeah. That's right. I just leaned right over Joe and I was like, no, he's not doing okay. And I aired the dirty laundry. I just went down the list of things that were going on. One of the biggest things where it took Joe, sometimes hours to get ready in the morning. And so I said to the doctor, does he need to get up like at 4 a.m. and take a pill so that when he needs to be up at 6 a.m. that, he can actually function? I said, and then, sometimes for no reason at all, or when he's under stress, his medication just stops working. It's the craziest thing you've ever seen. It's like somebody flipped a switch and the medicine stops working. I said, and then Joe's solution to this is to just take more pills or take another half a pill here and another pill there. And I said, by the time then, I would come back to Joe's at night to cook him dinner, then Joe would be so dyskinetic because it seems like all the medicine just digested at once. And then Joe wouldn't even be able to get a fork up to his mouth. So I asked the doctor about these things and he listened patiently and he said, no, you don't have to set an alarm for 4 a.m. and I'd rather you didn't. He said, I have something for you. He said, it's a subcutaneous injection.
That was the first time we had been dating 8 months that I saw her quiet. She quieted down. She was like, what did I get myself into? I knew what the doctor was talking about right away because my son's diabetic and I knew he had to take the needle. She probably thought it was somebody,
I did not
type thing when she heard sub. But she was real quiet and I enjoyed that moment very much.
Well, this movie started playing in my head and I see this nurse and she's drawing up a vial and she's finding a vein. And I'm just thinking, oh my gosh, I cannot do an injection. What have I done? And the doctor could tell that I was completely nervous about this injection thing. And he just said to us, I'm going to write you the prescription. He said, don't worry. A nurse is going to come to your home and she's going to teach you guys how to do it and titrate your dose for you. So we left.
Waited for the prescription.
We got a call from the Circle of Care first, who ran our insurance benefits, let us know what our copay was and if we would have one. The next call was from the Circle of Care nurse, and she set up a time to come out and teach Joe and me how to use the injection. Well, that day came and I was still not completely comfortable being there. So I left Joe with his mother. She was a retired nurse and I went to work. And about 5 hours later, I got a call from Joe's mom. And she's crying. And I asked about side effects and stuff at the doctor's office that day. Because as you can imagine, I was trying to avoid this injection situation.
She was like, he didn't sign the life insurance paper. She thought I died.
We weren't even married. Well, Joe's mom's crying. So of course, I immediately think something horrible has happened. When she finally catches her breath, she says to me, Joe wrote his name legibly for the first time in years.
That sounds kind of silly, but Catholic upbringing, Catholic school, handwriting was a big deal. Plus, by bank, actually, I had gotten calls from the bank manager a couple of times to thought my checks were being forged. That's how bad my handwriting had gotten to where I was actually using a stamp, which I don't like to do. But it was important to me to, when I was able to write my name legibly, it was kind of cool.
And it gives me chills even today to tell the story again. because that simple little thing that I take for granted every day was something that Joe's mom was sobbing over. And then she got excited and told me that, he buttoned the buttons on his shirt and he tied his shoes, and that she went up to his room and got him a tie and he tied his tie, and she was like, he picked a dime up off the floor. And I know all of this sounds very silly, but these are all of the things that Joe had lost in this disease that she had felt like he was able to do that day after taking the injection.
Yeah,
And then about about a half an hour after that, the nurse gave me a call. And she said that, I think we've already found the right dose. And she said to me, I'll be back to teach you how to use it. She said he had some nausea, but that's nothing that, we can't manage. So Joe will tell you about how the actual visit went since he was there.
Yeah, I mean, initially they put you on 0.2 the dose. There's as many doses you can find. The nurse was fantastic. She educated me. She became a family friend. It's just like unbelievable service. You have a nurse come to your house and teach you how to do things. And I took the initial shot right in my stomach, and no worries with it because I was real comfortable with the needles because my son being a diabetic, and my brother being a diabetic. The shot, I started to get it felt like a lot of medicine. It was a kind of weird feeling. And I started to gag a little bit and didn't throw up or anything, didn't pass out or anything. So the medicine takes like an hour and a half to go through your system, and then it wears off. And so they waited about an hour and a half. We started talking throughout the process, and they lowered the dose to 0.1, which is the lowest dose. And I reacted unbelievably to it. And like the buttoning in the shirt and the picking up the dime on the floor, when I'm in and off, my fine motor skills are horrible. I can barely move my fingers. I go from typing right away to like one finger typing. It's horrible. I get real stiff where I can't move my arms. So getting dressed in the morning was difficult. I had to get to work, get the kids off to school, drive. And when I took the shot, it felt like I almost felt like normal. I could do anything. It reduced all the off suffering I was doing. I felt really good.
And
so,
Joe also loses his neurological strength when he's in and off. He can't buckle a seatbelt. He can't sometimes, it takes him for a long time to lift a piece of paper and move it. It's just the strangest things that happen to people when they're in offs. But these are Joe's experience.
I used it to my advantage. I stopped taking the trash out. I stopped shoveling snow. But
not anymore.
Not the shot is really, I use it twice a day most of the time. The mornings are always difficult because the prior night I don't take my carbidopa levodopa. The last time I take is 9 o'clock. So I go 8 or 9 hours sleeping without any medication. So when I wake up, I can barely move. It's tough to get out of bed. I was like a mummy. So what I do is normally they're finding out now that a lot of Parkinson's revolves around the gut. Well, I would take my pill at 6 a.m., my carbidopa levodopa, and normally it wouldn't kick in until about 7 o'clock. So I'm sitting around for an hour, not doing anything, just trying to move. I take the shot with my carbidopa levodopa in the morning. The shot, the apomorphine kicks in within about 5 or 10 minutes where I'm on, and I get showered, I get dressed, I start doing my thing. And then when the shot's starting to leave my body, it seems like my pill kicks in. So I've gone from a up and down day all day long, never knowing what's going to happen, to a much more predictable, reliable day. It's much smoother because I'm real used to. I've been on the medication now for close to 7 years, and I've used it pretty much twice a day, every day. Some days 3 times, some days 1 time, always in the morning. And I never have real big offs. I'm living with the Parkinson's much better than I did with just taking my carbidopa levodopa. And the great thing is I haven't had to change any of my carbidopa levodopa. It's the same dose today than it was 7 years ago. And the best thing about this thing, I tell everybody, the efficacy on this thing is 96%. I tell everybody my car in high school didn't turn on 96% of the time. So it's phenomenal that it can be, it's so efficient. It's easy to use.
We carry it around with us. I mean, Joe carries it around with him. I have it in my purse all the time. It's doesn't need to be refrigerated or anything like that. It's super easy to use. And if he's concerned in the morning, if I'm not going to be home he'll preset his dose the night before, just click it and then it's set, and he'll just leave it on the nightstand. So then all he has to do is open it and then put it in him and take the injection. It's just it's so easy to use. And it's just nice to be able to carry it around and have it with us. Like Dr. LeWitt said, no matter how many pills Joe takes in the morning, they're not going to digest. He could take 100 of them and they're not going to digest. I mean, he needs this the first thing in the morning if he wants to get going within 20 minutes of being awake. And so this gets him going. And then it does give us a lot of peace of mind. I will say that, really after Joe started taking this, we were so we went back to the doctor for the follow-up, and, we were just so thrilled at how well this worked. And the doctor, said, do you want to tell your story? And we said, absolutely. We want everyone to know about this medication. And Joe and I started dating like a normal kind of couple after that. Joe wasn't worried about us going out to dinner, and him suddenly not being able to cut his steak or something like that. And, how embarrassing and emasculating it is for a man to have his, girlfriend cutting his steak for him at a restaurant.
I didn't mind that, honestly. I appreciate it. I was living large. That's the only bad thing about the medication. I can't fake it anymore. It takes a shot. I mean, I was getting away with everything, not getting catered to. But it's not happening anymore. It's back to normal. But we try to tell people that this medication, the way I understand it, what we've learned about it is it's going to work 20 years from now just as well as it works today. So it gives me a lot of hope. It's easy to use.
Yeah.
And
I've given it to him everywhere.
Yeah. And
in the car, I've given it to him in the car. We took dance lessons. I would give it to him before dance class. I've given it to him in restaurants, actually.
It doesn't make you a better dancer, but it gets you on the dance floor. So that's one of the things. But I always tell everybody, when I was coaching football, I always had a couple plays where we didn't use them a lot, but when we used them, they worked. And I always could count on that. And we practice them, and this has given me a lot of hope. I mean, I think I'm a better father. I think I'm a better husband, a better brother, better godfather, better coach. It's brought back a lot of my confidence where that was lagging, which I never had any problem with confidence. I was always very confident in things I had to do and I prepared, but this has really brought back my confidence, and we can't tell enough people about it.
And from a holistic perspective, I will say that having the confidence to go out, to socialize, to go exercise. Joe does Rock Steady. He does LSVT, loud and big and loud therapy. I used to have to reschedule his appointments all the time for those kinds of things because he just, he would get apathetic and wouldn't want to go. And now he's going and he's doing all of that extra work, all that other stuff that it takes to fight this disease. So from just kind of a holistic approach to fighting this disease, this we can say that this has helped us in that battle.
You attack challenges now, which I didn't attack before. I pretty much just, like I said earlier, sat on the bench. Now I'm attacking things and taking on challenges and feeling confident that I can handle it. And then if I can't handle it, at least I gave I tried, which I wasn't doing before. And it's so if you get anything out of it, just ask your doctor about it. That's what we try to tell everybody. Ask your doctor. And if it's right for you, it could be a big change in how you're living.
And I like to leave any caretakers that might be listening with, be your loved one's advocate, we want them to be their own advocate, but you be their advocate too, because every minute you get to spend with them is precious. So why not make those minutes the best that they can be? This is our story. Yours might be different, but we are so privileged to be able to share this with you and blessed to be able to share this with you. And I really hope that that hearing our story and that leaves you hopeful and feeling like maybe that this disease is not a death sentence. Mm-mm.
Well, thank you so much. I am so excited about this. And by the way, I do understand what you're talking about, but being able to write, sign your name and do these things again, because we watched my mom. She was undiagnosed for 4 years with it, and she was in the hospital for something else. And the doctor goes, "I think you have Parkinson's. I'm going to give you a carpet of Levodopa and just try to see what happens." And all of a sudden, she could do things she hadn't been able to do in 4 years. It was like she unfroze, and it was miraculous. It was like that movie Awakenings or whatever. It literally was like that. So I get it completely what you were talking about there. And now I love the idea that there's ways of fixing it after, you know, the carbidopa levodopa starts having its issues down the road. So this was great. Thank you so very much.
You.
Could I just add a few comments?
Yes.
First of all, I always love to hear your story, you Philadelphia kids, you. And
Thank you.
the story of medication responsiveness is a great one. Everyone's a little different. I don't think we should leave our audience with the thought that this is the cure for Parkinson's or that it will work that well for everybody. Some people have balance problems or swallowing difficulties, which create their own challenges. But this is a very typical experience of a very useful drug, one that's been overlooked by many physicians around the years, in part because to talk to your patient about it takes a little more time than handing over prescriptions saying, here, try this, or sorry, Parkinson's is a progressive disorder. You know, what do you expect? I mean, these are some of the answers that some people get. And remember, your doctor's office visit, among other things, is a visit to the complaint department. And you're entitled to have these things addressed. And you should come with a list of things written down so you don't get flummoxed by the doctor looking like they have another patient waiting outside. It's your time. Actually, by the complexity of your visit, the doctor earns more from Medicare. Keep that in mind. The more complaints you add to your story, the more he or she earns. So for all those reasons,
Well, that's good to know.
I think it's appropriate to say, I heard about a therapy that you inject, or I heard about a new drug that's longer acting, or I haven't tried all the options. There was a drug I was on a few years ago for tremor, and I'm not really sure that it didn't work, even though I'm not on it. Whatever it is, always be proactive, because the fallback position in many office visits with Parkinson's is, let's maintain the status quo. What do you expect? This is Parkinson's. And many doctors don't use apomorphine, won't have had the experience that Joe is telling us, which is quite routine with the drug for people who aren't getting the full effect from levodopa. In fact, sometimes I think this drug is even more effective than levodopa, except that it isn't practical to be giving yourself injections every 3 hours or frequently during the day. And yet, if we could, maybe we'd be doing even better for Parkinson's than with this drug levodopa that we've had for more than a half a century.
You're not going to remember this, doctor, but the first time I met you, he had told me that until we talked about, we were talking about aping, this was in, I guess, Flint, Michigan, when I first met you, and Dr. LeWitt told me that until all the doctors show you what's about everything that's available out there, medication-wise, will never break the glass ceiling. And that's why I use that experiment. If you walk into a deli, there's just one sandwich on the board. That's not really what you want. You want a variety. You want other options, and this gives you options. And I think it's important that you know that Parkinson's patients know that there's a lot of things out there that can help you, not just this, but ask, advocate, and there's so many good doctors that, you know, if you find the right cocktail of medications, you're able to exercise, you're able to socialize, you can live with this disease and you can live well with it. I mean, there's going to be bad days and some days that you really like, why me? And you'll whine a little bit, but those days are minimal now for me, because I found the right medications and I'm able to do a lot of things that I wasn't doing before. So stay hopeful and ask questions with your doctor.
Well, thank you so much, guys. I really appreciate this. Thank you for spending your evening with us. And I am so excited about having this video in our library, because it's going to be helping people for some time to come. So thank you very much. Brandon, thank you for putting all this together. Joe and Sarah, thank you for being here. Thank you, doctor, for being with us and sharing with us. I appreciate it so much.
Thank you.
Thank you, Jim. Thanks for having us.
Good night.
Thank you. Bye-bye,
Thank
guys.
you, and hope all goes well for everybody. Let me know if we can run this program again. For a great show.
I look forward to it. I'm sure we will. Thank you.
Good night, guys.
Bye-bye, guys.
Bye.